0 presents to the ER with complaints of abdominal pain and distension. What is your differential diagnosis?
My differential diagnosis would include both OB and gynecological etiologies as well as non-gynecological etiologies. From an OBGYN perspective, I would be considering ectopic pregnancy, pelvic inflammatory disease, tubo-ovarian abscess, uterine fibroids. From a non-gynecologic perspective, I would be considering diverticulitis, small bowel obstruction, postoperative ileus if she recently had any type of surgery. It's where I'm thinking currently.
Okay. How would you evaluate the patient?
I would start with a detailed history and physical exam, asking the patient when her symptoms started. Was there any acute or factors associated with the pain when her last menstrual period was? Any recent changes to her history? Any prior history of gynecologic issues in the past? Any recent surgeries? And then I would do a detailed physical exam, looking at her vitals, doing a abdominal exam, as well as a pelvic exam.
What would worry you in her abdominal exam?
I would be worried about any signs of an acute surgical abdomen, including peritonitis, rebound guarding. Yeah.
And what about her pelvic exam?
On pelvic exam, as for what would worry me?
Yes.
On pelvic exam, I would be worried if she had profuse vaginal bleeding, or if she had cervical motion tenderness or uterine tenderness consistent with PID, or if I felt any adnexal fullness concerning for a possible adnexal abnormality such as an ovarian torsion.
What diagnostic tests would you order and why?
I would first start with a urine, a beta HCG pregnancy test to rule out pregnancy. I then would complete some basic laboratory evaluations, including a CBC to evaluate for any leukocytosis, as well as a urine analysis to rule out any signs of urinary tract infection. I would then order a pelvic ultrasound.
Would you do any lab work?
CBC, as well as urine pregnancy, or as a pregnancy test as well.
So you're saying a urinalysis or a UTI will lead to distension?
An untreated UTI resulting in pyelonephritis could lead to sepsis and subsequently severe abdominal pain.
What's the pathophys on that?
The pathophysiology for an untreated, for a pyelonephritis leading to sepsis would
You said
be
abdominal pain and distension.
Urinary tract infections can cause lower abdominal pain, and pyelonephritis can sometimes cause abdominal pain, specifically also in the flank areas as well.
So that's abdominal?
For they can have referred pain with pyelonephritis.
Usually, how do they present?
They usually present with flank pain.
So how many pyelonephritis have you admitted in your career?
I have admitted, pardon?
Roughly.
Roughly. Probably about 20 to 30.
And what percent you'd say had abdominal pain? As their primary complaint?
Probably less than 10%.
They complain more of what?
Flank pain and urinary symptoms.
Anything else that you would do diagnostically?
Not at this time. I'd wait for those results to come back. Actually, I would also do sexually transmitted infection testing, especially if the patient had any evidence of mucopurulent discharge. I would test for GC chlamydia, gonorrhea, and trichomonas.
So let's say the patient gives a history of recent ovarian stimulation with an REI specialist. How would you manage the patient?
So given that history, I would be concerned about ovarian hyperstimulation syndrome. I would be looking for signs of anemia. And then I also I would manage the patient or I would treat her.
So let me ask you this. What is ovarian hyperstimulation syndrome? What's the pathophysiology there?
To the best of my knowledge, it is when patients undergo infertility procedures or workups and have excess gonadotropins and the ovaries overrespond.
And what increases your risk for this?
Patients who are at increased risk for this complication include patients who undergo IVF, specifically with gonadotropin stimulating agents. Patients who have had, I believe patients who have had multiple IVF procedures in a row. That is all I can think of at this time.
So how would you manage the patient?
I would manage this patient by treating her symptoms. I want to say that sometimes these patients need anticoagulation, but I'm not 100% sure of that and would have to look that up prior to treating her.
And what are signs and symptoms of a worsening condition?
Signs and symptoms of a worsening condition would include worsening abdominal pain and distension, worsening laboratory values. Yep.
So you said you would treat anemia. Anything else you would do? You'd give her anticoagulation, you said, correct?
Yes, I believe that is part of the treatment, but again, I'm not 100% sure. I would have to double check before I treated her.
Anything else that you would be worried about?
I also believe that these patients can present with electrolyte abnormalities, so I would correct those as well if they were present.
Anything else that you would do?
I would also contact this patient's REI specialist and let them know of her complication and involve them in her care.
Yeah, of course, he's not going to have privileges at the hospital. It's all hospital-based. So what else could you do? Who else can you call, I guess?
I am not sure right now.
Let's say she was pregnant. Would you be worried?
Yes, if she was pregnant, I'd be worried. I could involve my MFM colleagues.
Would they do anything special?
I do not think so, but I'm not 100% sure.
Okay, what'd you think?
That went in a very different direction than what I was thinking, and I completely forgot about ovarian hyperstimulation syndrome.
So what direction do you think it was going?
I thought it was going to go into a torsion or a TOA picture.
Okay. All righty. Yeah, Not an easy topic, right?
No, there's just some things that I can see, like a slide that I studied before in the past. I just can't remember the specifics right off the top of my head.
The only thing that I was a little bit concerned about when, I don't know if it was in the diagnostic or probably diagnostic when you said you do a urinalysis, and to say that, I'm not saying you won't have lower abdominal pain with a pyelo, but it'll be more flank pain.
Mm-hmm.
So, I mean, anybody can present with anything, but then that's why I said, well, how many pylos have you admitted in your career? You know,
Right.
not to put you on the spot, but to say it's a low number.
Yeah.
So, any specific questions before we go over OHSS?
Not that I can think of.
So it's a shift of serum from the intravascular space to the third space, mainly to the abdominal cavity in the context of enlarged ovaries due to follicular stimulation. So what increases the risk? Prior episode, PCOS, and AMH greater than 3.3, antral follicle count greater than 8, high number of oocytes retrieved, HCG being administered, high estradiol level, pregnancy after stimulation, where rising HCG secretion from the placenta can stimulate vascular endothelial growth factor secretion from the ovary. Order CBC, creatinine, electrolytes. You could have elevated LFTs, get an ultrasound. So this is from Up to Date. They said there's like different grades. They didn't give them a name, but they say mild is abdominal distension, discomfort, mild nausea and vomiting, diarrhea. You could treat with Tylenol, no NSAIDs, avoid heavy physical activity, manage as an outpatient. Then you have moderate, presence of mild features and ultrasound evidence of ascites, oral intake of 1 to 2 liters a day, monitor for worsening signs via labs and weight, abdominal circumference measurement, monitor urine output. You can manage as an outpatient unless the condition is worsening. Severe, you have a hematocrit of greater than 55, so not anemia. WBC count of 25,000, creatinine greater than 1.6, clinical evidence of ascites, severe abdominal pain, intractable nausea and vomiting, rapid weight gain, oliguria, VTE. Must be hospitalized, get VTE prophylaxis, like you said. It's a multidisciplinary approach. Supportive care, cholecentesis for removal of tense ascites. If you're not pregnant, you should see resolution in 10 to 14 days. It's usually delayed if you're pregnant. It is considered a life-threatening condition because it can cause venous or arterial thromboembolic events, stroke, loss of perfusion to an extremity. Okay. So questions?
No, thank you. That was helpful. Just have to learn how to not keep
Like,
going.
I'm not going to say you're going to get this question. It's but they'll give you some weird thing and you're like, oh, what they're talking about. And then you try and dig down and see what you can get.
Yeah.
But I mean, I think you did fine with your differential, how you evaluate the patient. I guess, again, the UTI, I was kind of like, okay. Again, just because you didn't know the zebra question or the last question in the structured case doesn't mean you got it all wrong.
Right.
It's the thought process that's important. That's
Okay.
what they're looking for. Okay.
Thank you.
All right. Very good. Good job. All right, Jose, I'm going in your direction. Just to see if anybody has any questions. I'm sure as the hour progresses, people would have questions. Oh, I see a question here. No, Genevieve, you wouldn't. I don't think you would lose points. I mean, it's brownie points if you have it in the differential, but I think putting appropriate items in the differential is what's important, and how you would evaluate the patient and your diagnostic tests accordingly. So, I mean, you won't get full credit, but you're not going to get points deducted. I mean, it's always better to get what they're looking for, right? Okay, Jose, I'm going in your direction. So after Jose comes Stella, followed by Ankita. Okay, that's the list I was given. It says you're self-muted, Jose.
Okay, here I am. Yeah.
You got it. Perfect.
Yeah.
All right. You ready?
Yes, I am.
Okay. After performing a hysteroscopic myomectomy, Your partner's patient appears confused and disoriented in the recovery room. How would you evaluate the patient?
Well, first of all, I will need to go obviously to the bedside and see her clinical status. I'll be in the physical examination, be concerned for signs of pulmonary edema or pulmonary effusions. So I will see her oxygen saturation, I'm hoping for them to be normal, verify if there's any evidence of tachycardia. And then after that, I mean, if the patient appears to be, I will do obviously laboratories. I will be concerned for hyponatremia. Yeah, I will start from there. I will start based on her vital signs. If there's concerns for fluid retention, I will start aggressive diuresis. And if that's not the case, then I just baseline management based on the lab findings.
So on your evaluation, how would you know if there's concern for issues in the lungs, for example? What are you looking for?
Or I'm looking for crackles when I do my physical examination and auscultation. I'm looking for tachypnea, probably oxygen saturations that are below 95%. There could be also tachycardia. Those will be the findings that I'll be concerned with.
Okay. So what diagnostic studies would you order and why?
Well, I'll start ordering a CBC. I will be concerned if there are some significant blood loss during the procedure. So I'll be interested in knowing the hemoglobin. I will also go back and review what was the fluid deficit during the procedure, which would be important
So
also.
what fluid deficits would you be concerned about?
I will be concerned about any fluid deficit above 500, depending on the comorbidities of the patient. Healthier patients, one will consider up to 1 liter of difference or fluid deficit to be acceptable, but anything above 500 and this clinical presentation, I will be concerned of.
And what's the maximum that's usually accepted for a fluid deficit?
Anywhere from 1,500 to 2,000 will be the maximum that will be acceptable.
Now, is it a factor what type of distension media you use?
Yes. Well, I mean, in terms of the fluid deficit, you essentially will use the same metrics. Yes, there will be concerns in terms of the medium that I'm using. For instance, if I'm using a hypotonic medium, such as mannitol, that the patient could have severe hyponatremia and be third spacing. In which case that will be concerning for patients to start having seizures. Then, whereas if I was doing some isotonic solution, I will be looking more for pulmonary edema as well, or more focus on that and not least concern for the.
So, what other distending media are available during a hysteroscopy?
Well, you could use mannitol. You can use Ringer's lactate. You can use normal saline. Those are usually the first that will come to my mind. The importance would be the ones that one would be ones are isotonic, and those are the ones that you'll be concerned for severe electrolyte deficiencies.
So I'm sorry. So you said so which type causes electrolyte imbalances? I'm sorry, I missed that.
The hypotonic.
Hypotonic being.
Hypotonic being there will be a tendency for third spacing because it's hypotonic in reference to the plasma of the patient.
Any other diagnostic tests you would order?
Other than CBC and the basic metabolic profile, I will depending on my findings, I could also consider doing imaging, for instance, an ultrasound and a chest X-ray.
What would the ultrasound show you?
Well, the ultrasound, I'll probably will be doing it just concern for free fluid in the abdomen, for concerns of a perforation that could be causing the patient to be kind of like disoriented. That obviously will come along other abnormalities on the physical examination and the vital signs.
So how would a perforation lead to disorientation?
Well, if the patient is bleeding intra-abdominally and her hemoglobin is dropping, that could cause altered mental status.
Is there another pathophysiology, something else from the perforation? Let's say she's not bleeding.
Let's say she's not bleeding. I mean, I'm not sure what the question.
So let me ask you this: if you perforate somebody during hysteroscopy, would your fluid deficit be low, normal?
Gotcha. Yeah, well, there will be if there was a perforation, probably will be a high fluid deficit because the fluid could have gone through the myometrium and get into the pelvic cavity.
So any other diagnostic studies that you want to add?
Well, she's post-operative. If she has chest pain, might as well rule out DVT, and we could do a chest CT, a CT angiogram that will actually evaluate for fluid on the lungs as third spacing, and will also a.
But you would only do the CT if she had chest pain. Is that what you were saying?
Yeah. Yeah. I would do a chest CT, and then I mean, also disoriented. I guess that it will be also appropriate to do a head CT, rule out that the patient is not having some thromboembolic event to the brain, having some sort of hypoxic brain injury.
So how would you manage the patient?
Well, this patient will probably, I mean, depending on my workup, will be the management. But let's say, for instance, that I'm concerned for having fluid overload, then I could start doing diuresis, which would also be the case if I'm concerned for hyponatremia. In severe cases of hyponatremia, you could actually give hypertonic saline, 3% saline solution. That would be also an alternative. If there was some concern for a perforation or any kind of intra-abdominal process, something that could be considered would be doing a laparoscopy, but that would be kind of. And the other thing, if I'm concerned for any thromboembolic event, I could start I could start her on blood thinners. So
again, why would you do a laparoscopy? I missed that part.
Well, if I were concerned for some sort of intra-abdominal bleeding that might have been secondary to the hysteroscopy or perforation, and the patient is deteriorating clinically, that would be something that would benefit the patient if a diagnostic laparoscopy to see if there's anything that needs to be repaired.
Now, would the presentation of the patient be different? I didn't catch that in your discussion. Depending on, like, let me put it this way: if somebody used isomolar fluid, how would she present if she had a high fluid deficit? Possibly, if it affects her.
Well, she could present with altered mental status and seizure because of hyponatremia. You said
so that's if it's isomolar, normal saline or LR, correct?
No, that will be if it's hypotonic.
Hypotonic.
Yeah.
What if it's isotonic?
If it's isotonic, it could I would be thinking more of the shortness of air and third spacing.
which is usually called
Pulmonary edema?
something
No,
else?
actually, pulmonary effusions. Yeah.
Say again?
Pulmonary effusions.
Effusion. Okay.
Yeah.
So how could this be prevented in future procedures?
Well, the most important thing will be having a very close monitoring of the vital signs of the patient, and having, ideally, if you have it available in your institution, some sort of automated system that will do the intake and output throughout the procedure, stopping the procedure, pass or start having, like, considering to stop the procedure if the patient is showing any kind of symptoms and the fluid deficit is already at the 500. Most definitely, if it went above of that and the patient is deteriorating, just start the procedure. And I think that's the only thing that I would have done differently.
Okay, what do you think?
I think I was thinking out loud. But I mean, yeah, to this point, I mean, like, these are very open-ended questions, so it doesn't push you towards one or another. I mean,
Right.
obviously, examiner would, but kind of like, yeah, I didn't. Up to this point, I know exactly what we're dealing with. What exactly would have been the diagnosis or the idea of this case?
Because a lot of stuff, it is open-ended. So then what I tell everybody is, to go back to your like evaluation or your diagnostic studies. So how would you manage the patient? Well, if I see she has electrolyte imbalances, I would proceed with correcting those, and they may ask you questions specifically about that. If I did a chest X-ray and it showed pulmonary edema, I would start a diuretic. You see what I'm saying?
Yeah.
So it gives you opportunity to take a little bit of control. If they don't want to hear it, they'll just cut you off.
Okay.
Okay. If they
Right.
feel, in the end, if they feel a topic, they're going to cut you off, and they're going to keep trying to find something they want to trip you up on. Because they suspect, this is my thought process, I could be wrong. If they trip you up on something, is that going to trip you up in other things? Because you keep thinking about the thing they tripped you up on. Because you walk out of the test, you're only going to remember the stuff you didn't know. You're not going to remember the stuff you did.
Okay.
That's why everybody walks out thinking they failed.
Okay.
Right?
All right. Yeah.
So any specific questions on this before I go over it?
No, not particularly. I mean, again, the observation is kind of, it's very difficult to not sound like you're just kind of like saying scatter ideas, and you actually have a organized thought process. Obviously, when kind of they're so open-ended, like, it could be anything. So you want to cover all bases.
So that's why just go back to, well, if I listen to her lungs and I heard crackles, well, I'm concerned about pulmonary edema. I will treat her with Lasix or whatever. And then if they don't want to hear it, they'll just cut you off.
Okay.
Yeah. Okay, so how do you prevent this in future procedures? So what's key is what type of distension media do you use? Your fluid deficit or issues with hyponatremia, usually where the person will be with altered mental status, confused, will happen more often with your hyperosmolar. Okay, so when I was a resident, that's the only distension media we had. And then came the use of normal saline and LR. So really the side effect of fluid overload for that is fluid overload, congestive heart failure, pulmonary edema, that type of picture. Can you have also electrolyte imbalances? Yes, but it's going to be at a higher level. It's more common with the hyperosmolar. I'm not an expert, but that's to my understanding. So how would you prevent this in future procedures? Fluid overload and hyponatremia can be prevented by avoiding the use of non-conductive or non-electrolyte irrigation fluids if possible. Minimize fluid absorption by using low infusion pressures and limiting the duration of surgery, usually to less than an hour. So if you have a big submucosal fibroid, you have to transect. You may have to do it and tell the patient. You may have to do it in a stepwise fashion, because if she enters a high fluid overload, or I should say a fluid deficit, you're going to have to terminate that procedure. So monitor the quantity of fluid absorbed. Everybody has those special apparatuses that do that if they're working correctly. Stop the procedure at predetermined absorption threshold. So electrolyte fluid, the max is 2,500. That's in a healthy person. If somebody is older, you may want to stop it sooner at 1,000. You know what I'm saying? Electrolyte fluid will be at 1,000 cc's. If you're an older person, 500 cc's. Also, vasopressin injection in the cervical stroma may reduce the volume of fluid intravasation. So, because you have that constriction in that area. You could also tell the anesthesiologist to limit the IV fluids. Okay. So what are different types of distension medium? You have glycine that breaks down to ammonia. Sorbitol, it's glucose or fructose. Mannitol is not metabolized. Okay. So hyponatremia should be suspected whenever large volumes of non-electrolyte irrigation fluids have been used, when operative time is prolonged, or patients develop new neurologic symptoms during the postoperative recovery. These neurologic symptoms are greatest when the fluid absorption exceeds 1,000. That's for like the glycine, sorbitol, those distension medias. Okay. In such patients, the serum sodium and osmolality should be urgently measured. Okay.
Okay.
A decrease of serum sodium of 10 milliequivalents a liter or more are likely to develop neurological symptoms. Okay.
Okay.
Fluid absorption into a vascular space rapidly decreases sodium. It is a slower process that extravasates as into the peritoneal cavity. But you could have perfed her, and that could lead. But of course, if you saw that she perfed, you wouldn't be your fluid management would start telling you, hey, you're having a big deficit. Okay.
Yeah.
So just an overview. I don't know if they'll ask you this, but just an overview. Bipolar, cautery, for lack of a better word, use isotonic saline, lactated ringers. You have fluid overload causing pulmonary edema, congestive heart failure there. For monopolar, electrolyte poor, that's 1.5% glycine, 3% sorbitol, 5% mannitol. It leads to hyponatremia, hyperammonemia, decreased serum osmolality, potentially leading to seizures, cerebral edema, and death. Glycine is metabolized to serine and ammonia. Sorbitol is glucose and fructose in the liver, and then to carbon dioxide and water. Mannitol does not enter the cells, and it's not metabolized. It is excreted entirely in the urine. This is according to the practice bulletin on hysteroscopy, which is from a while back. I have not noticed that this has been updated. Specific therapy is not necessary for asymptomatic hyponatremia or when symptoms cannot be assessed because of anesthesia for a serum sodium reduction of 5 milliequivalents per liter or less. If kidney function is adequate, then the excretion of the excess water and metabolism and excretion of the infused non-electrolyte solute will rapidly correct the hyponatremia. So you said hypertonic saline, okay? Hypertonic saline is indicated in symptomatic patients with marked hyponatremia who have a substantially reduced serum osmolality or cerebral edema. In addition to reducing cerebral edema, hypertonic saline replaces the potentially substantial urinary sodium losses that result from the osmotic diuresis caused by the distending media. When hypertonic saline is given, the patient is initially given 100 cc's of 3%, you said that, as a bolus, which provides 51 milliequivalents of sodium and should acutely raise the serum sodium concentration by 2 to 3 milliequivalents per liter. If the neurologic symptoms do not improve, a 100 cc bolus of 3% can be given 1 or 2 more times at 10-minute intervals. Rapid correction of hyponatremia and hypoosmolality is probably safe following hysteroscopy. Because of the extremely short duration of hyponatremia, there has not been time for the cerebral adaptations that put patients with chronic hyponatremia at risk for osmotic demyelination or central pontine myelinosis. Although demyelination is often more diffuse and does not necessarily involve the pons. If the serum sodium is raised too quickly, Okay. Nevertheless, ACOG guidelines conclude that the serum sodium should not be raised by more than 12 milliequivalents per liter in the first 24 hours. The rate of correction should be slower, 8 to 10 maximum increase in the first 24 hours in patients who present with hyponatremia more than 48 hours after the procedure. Okay. That was from the practice bulletin. So questions on that?
No. I mean,
More than I ever want to know about, you know, hysteroscopy. So the first thing I would have done in this case, and that's why I said would be your partner did it. You just assumed it was normal saline, but what if it's an older partner? There was something wrong with the bipolar and they used monopolar, because then your management could be different, right?
mm-hmm.
If you got found out, you would freak out more if, let's say, glycine had been used, right? I know I would. And the first thing I would say is like, why is he using glycine?
Mm-hmm. Okay.
Okay.
All right.
All righty.
Thank you.
All right. Very good job. Thank you.
Thank you.
So Jules asking the question, in standard cases with examiners tell you what the lab's imaging exam findings show so that you can guide your answers better for management prevention. When I took the test, they didn't. I have heard more recently, they are kind of guiding you in certain directions with the results. And I know somebody told me a couple of years ago, they actually, one of the questions in the vignette or the structured case was, at this time, the examiner is going to do like a free talk of whatever topic they wanted within, I guess, the realm of what the vignette was about. So I found that kind of odd because it wasn't structured. So I think things do change as time passes. But when I took the exam, they didn't give you anything. I've heard they're doing pictures now. Somebody told me they once got a fetal heart rate tracing, but very basic that you would know. So hopefully that answers your question, Jewel. If the prompt is patient is confused and disoriented, is it incorrect to say I would evaluate my ABCs, or is that obvious? I'm rehearsing my answer for post-op complications, but I would definitely always do my ABCs. Because because remember, this is just a theoretical patient. When you walk in the room, you know exactly if she's doing okay breathing, and it might be just fermentation, but I don't see anything wrong by going by your ABCs. I would just make sure my ABCs are in check, and then I could just go straight to evaluation of whatever else. There's nothing wrong with that. Same thing if somebody has a seizure, you always want to do your ABCs, right? You always, go to the basics and then build from there. So hopefully that answers your question there, Melody. So Maya's asking, if a perforation happens, do you have to automatically inspect the abdomen through laparoscopy or open procedure, or do you only do this if you have a high suspicion of vascular or bowel injury? To my understanding, I'm not an expert. It depends what instrumentation. If you had a sound, you're not going to really damage anything on the other side if it was fundal. What I would do would be serial crits. I would do for that patient. But let's say you had something that was thermal at the end, something that could cut, then there's a higher suspicion you could have caused some damage. What if it went to the side? Could you have gotten the vascularity of the uterus? Because it's not a fundal perforation, it's more on the sides. In those type of situations, I think you need to at least put a scope in to make sure you haven't missed anything. Tawana saying central pontine myelitis is less common patient because this is acute hyponatremia. It's the correction of the hyponatremia, if it's done too quickly, leads to that central pontine myelinitis, to my understanding. Okay. And according to ACOG, we can replace it kind of on the quicker side. And of course, you're going to call IM to help you out. You're not going to do this on your own if this happened. If it happened like in the recovery room and you notice it, you can take care of it quicker. I guess if it's more time has passed since the procedure, that's when you have to take it more slowly, or if it's a very low level, you don't want to correct it too quickly, because that's when you have the central pontine myelitis occur. Okay, so hopefully that answers your question there, Tawana. All righty, Stella, I'm going in your direction. And if anybody has any questions, just put them in that question box, okay? And hopefully we'll get everybody's questions answered. Stella, are you there?
Yes.
Are you generalist or subspecialist?
Generalist. Yes.
All righty. Perfect. Any questions to this point?
No.
Okay. 13-year-old para 0 presents with lower abdominal pain. How would you evaluate the patient?
Okay. So for a 13-year-old with lower abdominal pain, I will start by finding out the onset of the pain, and then what makes it worse, and what makes it better. Radiation, there is any radiation. Also want to find out about severity, and again, if she has associated symptoms of nausea, vomiting, diarrhea, headache, feeling chills. Then I will also want to know if she's sexually active, and a history of her last menstrual period, or rather history of her menstruation, then last menstrual period. And I will move on to, get the vital signs, then abdominal examination.
What specifically would you be looking for in your abdominal exam?
Yeah, that's where I'm going to right now. I will be looking for guarding, or voluntary guarding or involuntary guarding, rebound. These are the things I'm looking for. Then also listen to abdominal, bowel sounds. And then moving on, if she's, I will do pelvic exam if she's sexually active. But if not, I will do vulva inspection. And if the parent is with the, is present, then I will also may do rectal examination. Yeah. So
I'm sorry, let me interject. What type of examination? I didn't catch it.
No, I said, since if she is not sexually active, I would do
right. You would do rectal exam. Okay, I didn't understand. Rectal exam.
Right.
Okay, got you.
So I will go ahead and also do the labs.
So let me just hold there for a second. Anything else in your evaluation that you would want to know in either your history?
With the rectal exam, I will, it will give me an idea of, the pelvic status. If there is any tenderness, I can do that also abdominally, the adnexal tenderness and suprapubic tenderness, I can do that. Yeah, so these are the things I'm looking at.
Okay.
And, as far as the labs,
hold on a second. Hold on. So what diagnostic tests would you order and why?
Okay, the diagnostic test, I will do beta HCG, rule of pregnancy. I will also do NAAT for STIs to, rule out any sexually transmitted infection. And then CBC, if there is any infection ongoing, that will help me with, any elevated WBC. I will also do CMP. That will help me in case she said vomiting, look at the lights. Type and screen will be done as well. And then
why would you do it? Why would you do a type and screen?
I'm just I wouldn't know if this patient is having, I wouldn't know if she's pregnant and having ectopic pregnancy. So in case I have to take her to the OR, so I'll have to be proactive. I will get the type of screen. So then I will do a pelvic sonogram. If she's sexually active, it should be transvaginal. But if she is not, then transabdominal.
Okay. So an ultrasound revealed the following.
Okay, ultrasound.
Describe this image.
I'm looking at twin peak. Most likely, yeah. Most likely multiple pregnancy.
So an MRI revealed the following. Describe this image.
MRI. Is that a ground glass image to the left? I can't figure what's in the middle. Yeah.
So let me ask you this. Do you see the uterus on this picture?
Am I right about this? I honestly, I can make out what the white stuff in the middle. If it's, yeah, I can make out if it's a uterus or bowel in the midline.
Discuss how you perform a hymenectomy.
Hymenectomy, okay. Okay. Hymenectomy, usually I believe that this has to be done by a specialist like a REI. However, if I have to describe it, a crochet incision will be made. In order to release the blood in the vagina. And again, I believe it has to also, I believe either estrogen will be applied to avoid the incision healing again. That's what I can recall.
So once you make your cruciate incision, do you do anything else to the tags, the hymenal tags, or you leave them be?
Yeah, that's what I'm thinking right now. I know something else is done. I believe it's trimmed. It's trimmed. But there's something that would be done to avoid the re-adhesion.
And after you trim them, do you do anything else?
Yeah, that's what I'm thinking. I know something is done to avoid re-adhesion, but I can't record that right now. Yeah.
So that's the end of this case.
Thank you.
Okay. Let me show you. Okay, so
I can't figure.
So this is the uterus. This is the vagina full of blood, and that's, I think, the bladder deviated because of the vagina.
Oh, okay, because it's not in the right position. Okay. All right.
I'm not I'm an expert, but that's what I think that is.
Yeah, I haven't seen this picture before, ever. It looks more like endometrioma.
Okay, so here are different anatomic variations of the hymen. And of course, the patient had the imperforate hymen.
Mhm.
Okay.
Yes.
I don't know if they'll ask you that, but there are the pictures.
Oh.
Okay. So how do you do a hymenectomy? It's indicated in the presence of imperforate hymen, creating, like an example, hematocolpos at menarche, or perforated hymen with a hymenal hypertrophy obstructing intercourse. The latter can be frightening and can be associated with major hemorrhage if the lateral pudendal artery is lacerated along with the hymen during initial attempted relations. Hymenectomy is performed to open the hymen without hemorrhage and to leave a patent introitus. Caution should be observed in performing this operation in a facility where adequate resources are not available for control of hemorrhage. Okay. So you do a cruciate, stellate, elliptical. That's what UpToDate says. X, to me, the X makes better sense, is made to open the hymen. You gently irrigate if you want to do that. The hymenal tags can be grasped with tissue forceps. And each hymenal tag is elevated with the forceps excised at the level of the introitus, and the base is sutured with interrupted 3/0 synthetic absorbable suture. So I'll keep everything kind of patent. And that's straight from the Atlas of Pelvic Surgery, WELIS, which you can look up online, and it's free. It's a very good text to see different procedures in GYN surgery. So questions. I thought you did very nicely with your evaluation. I mean, it's the curveball, right?
Yeah.
I'm trying to get you ready for the curveball. Hopefully they don't give you a curveball, but you did very nicely with your evaluation. I would do this, I would do that. What you did with your diagnostic tests, I would do this and I would do that. So very, and then comes the zebra.
I like these zebras. I rather have it now.
I'm not saying you're gonna get this question, but it throws you for a loop, right?
Yes.
I know somebody a few years ago, unfortunately did not pass the exam several years ago, and was doing a mock oral, and I said, where do you think did you lose it? He goes, the first structured case, that it was about hepatitis. I lost it from there on in, because why would you be asked a question about hepatitis in an OBGYN exam? But again, everything, we're considered primary care, so everything's free reign, right?
Yes.
And he said, I couldn't get back on the horse and keep it going. I lost it at that point. So, but very good job.
Thank you.
Questions?
I'm wondering, for the MRI, I'm wondering why the uterus is white.
It's full of blood. It's full of blood. It all gets backed up.
Okay, so that's how it looks
like. She comes in with the pain, right?
Okay, great. Thank you.
Okay, yeah, no worries. I know when I first saw it, I went, what? And then you start looking at it, go, now I'm seeing it.
I've never seen it before.
So Tawana, which image do you want me to go back to? The ultrasound or the MRI? Very good job, Stella. Okay.
Thank you so much, Doctor.
Yep. Very good.
Yeah.
I haven't gotten a response for Tawana, so we'll go on to the next one. I am going now to Ankita. I'm going in your direction here because I know you were here. It says are you there, my friend?
Hi, yes, can you hear me?
Yeah, I can hear you fine. Thank you. All right. Let's see. And you're a generalist, correct?
I am, yes.
31-year-old para-0 with a 7-centimeter unilocular simple appearing ovarian cyst on ultrasound underwent an uncomplicated laparoscopic cystectomy. The final pathology revealed a low malignant potential tumor. How would you counsel the patient?
So when I see this patient, I would counsel her on the surgical findings first, what we saw during the surgery, the laparoscopic, like what we saw during the laparoscopic surgery, and then I'll go over the pathology results with her. I would tell her that the pathology shows this tumor could have a low malignant potential. So we do need to closely follow up. I would order a CA-125 for her to know what her CA-125 is at this time. And I would have her follow up with a gynecologist, oncologist, so she can, she can be under close observation with them as well.
So she's asking you prognostic. What's her prognosis? What would you tell her?
A low malignant potential tumor is a very, the risk of it progressing to malignancy would be low and slow for that matter. So her prognosis at this time would be good as long as she keeps following up with serial ultrasounds. If there is any cyst developing on the other ovary or even on this ovary, then we would have a low threshold for doing another surgical exploration. I would also ask her if she has any, if she does want to get pregnant. If she does, then I would counsel her regarding, conception sooner rather than later, or at least consider egg freezing, because if, in case we have to go ahead and proceed with a bigger surgery in future, depending on how her monitoring goes, then at least she would be able to have a planning for her fertility in future.
So what staging procedures recommended with a borderline tumor?
My understanding is that with a borderline tumor, surgical staging would be the same as with any ovarian malignancy. However, it will depend on patient's age, her desire for future fertility. The surgery would depend on those things, but the staging itself, my understanding is would be like any ovarian malignancy, but I'll have to review that.
So she is nulliparous. Will they have to take her back to the operating room to stage her?
With her, she is nulliparous. After having a full discussion with her, that the chances of this tumor being malignant is low at this time. And what her, is she concerned about a malignancy at this time versus is she more concerned about preserving her fertility? We'll need to have a full discussion with her about that. And if she is, if she understands that this is a low malignant tumor, the risk of frank malignancy is low. The prognosis at this time is good. However, we cannot 100% guarantee how, when this might change. She's okay with monitoring, then she may not need to go back to the OR right away. But if she's extremely anxious, she does want to have surgical staging, that could be an option after a full discussion with her.
So let's say the patient is interested in full staging. Is a lymphadenectomy recommended? Yes or no? Or is it beneficial?
For this type of tumor, I would I would think that lymphadenectomy should not be essential.
It would not be essential. Why would you think that?
Again, because the tumor, the final pathology reveals a low malignant tumor. However, if she does go back for surgery, with the gynecologist, oncologist, I believe they would get pelvic washings, to see if there is any concern. And if it is positive, then yes, they would do a lymphadenectomy. If there's any concerning signs during the staging of any other suspicious findings in the pelvis, or if there was any during the surgery, if there was a breach of capsule, then yes, then lymphadenectomy or at least lymph node biopsy should be done.
So only if you had a higher stage, or you suspect a higher stage, is what you're telling me.
That is my understanding, yes.
Okay. So what tumor markers in adjuvant therapy are endorsed?
For simple appearing unilocular cyst, a tumor marker would be CA-125. And then I don't believe she would need an adjuvant therapy for a low malignant potential tumor, but again, I'll have to double check that.
So you don't think she will need any chemotherapy?
I don't believe so for a low malignant potential tumor, no. However, I'm not sure, and I'll have to double check.
The patient's interested in having children. What options are available?
So options available are she can, as long as she's not going straight to surgical staging, if she wants to avoid that, she can try conceiving naturally. She can always do egg freezing with the infertility specialist before going forward with surgical staging procedure.
Now, is there any way where you had said her prognosis should be pretty good, she can maintain her ovaries for fertility? Did I understand that correctly with your discussion earlier?
Yes.
So let's say she's done having children. Should she have complete staging at that point, or complete removal of everything, I should say?
It's not. I think with a low malignant potential tumor, it's not necessary, again, because the prognosis is good. She definitely needs to have very close monitoring, but she doesn't necessarily need to have surgical staging as soon as possible. But she would need to be really counseled well, by me and also by the gynecologist oncologist, and given all her options, and whatever she chooses at that point is what we should do. But I wouldn't say that she absolutely needs to have it right after completing family if she's still in her early 30s.
Now, let's say she's having difficulty conceiving. Can she undergo ovulation induction? Is that a contraindication?
No, it is not a contraindication. She can get ovulation induction.
Even though she has this low malignant potential tumor?
Yes, because even with patients with ovarian cancer, they do get ovulation induction and egg freezing prior to their surgical staging. So she can have ovulation induction for egg freezing.
How about not for egg freezing, just to try and get pregnant?
I would believe that would be okay too.
Okay. All right. What'd you think?
I think I was having a verbal diarrhea. I don't know.
I mean, I actually like, I mean, look, if I had gotten this question in my exam, I would have gone, what's it? I'm out of here. I mean, this is not an easy topic.
Yeah.
I mean, you didn't get it 100% right, but I don't think they expect anybody to get this 100% right unless you're an oncologist, right?
Yes. I
Right?
think I was
So,
speaking faster than I was thinking.
but I thought you did, I thought you did well. So do you have any questions before we go over it?
No, let's go over it.
So like, this is straight from Up to Date. And I reviewed it and everything appears up to date. Nothing's changed because I did this question about two or 3 years ago. So I wanted to review that nothing had changed. So how would you counsel the patient? Because of course they're going to call your office freaked out when it's on my chart and you haven't called them. It's a good prognosis, stage 1 with a 5-year survival of 99%, and a unilateral salpingo oophorectomy appears to be an option for women with unilateral disease. Overall risk of recurrence after conservative surgery is 7 to 30%, and recurrences show borderline histology, not invasive cancer. A CA-125 is not beneficial in borderline tumors. So you did say you did a CA-125. Apparently, it's not beneficial. So staging is the same as for ovarian cancer. The complete staging procedure for patients in whom future pregnancy is not desired includes a total hysterectomy and a BSO, peritoneal washing, omentectomy, and resection of grossly visible metastasis. More conservative surgery may be performed in patients in whom future pregnancy is desired. So is a lymphadenectomy recommended with a borderline tumor? It has a low prognostic utility, 98% survival at 6.5 years in women with lymph node involvement. So therefore, it's not really worth it, right?
Mm-hmm.
For patients with an apparent unilateral stage 1 borderline ovarian tumor who wish to preserve fertility or endocrine function, we suggest, that's up to date, a salpingo oophorectomy of the affected ovary, pelvic washings, an omental biopsy, and a biopsy of any peritoneal lesions rather than full staging for ovarian cancer. All macroscopic disease should be resected. An appendectomy is performed for mucinous tumor, so if you have a borderline mucinous. It is controversial whether patients who have fertility-conserving surgery should undergo removal of remaining ovary or uterus upon completion of childbearing. The presence of micropapillary features is associated with an increased likelihood of both invasive peritoneal implants and of recurrence. For patients with stage 1 ovarian borderline tumors treated with either USO or ovarian cystectomy with an average follow-up of 3 to 6 years, the borderline recurrence rate was 13%. Recurrence with malignant disease was 1.6%, and the death rate was 0.5%. Some data suggest that USO is more effective than ovarian cystectomy, especially if the margins are positive or the resection is incomplete. The recurrence rate was higher, and recurrence occurred sooner after cystectomy. Recurrence of borderline disease requires surgical resection, typically full staging. If no malignant disease is present, borderline recurrences are not associated with mortality, in some cases, even after a recurrence. The uterus and one ovary or part of an ovary may be conserved to retain fertility. Chemotherapy is rarely indicated for patients with borderline ovarian tumors. While most clinicians would agree that there is no advantage for chemotherapy in patients with early stage, completely resected disease, its use for those with more advanced stage disease is controversial. There is no evidence that patients who undergo fertility-sparing surgery and become pregnant are at an increased risk of mortality from disease progression. Fertility treatments such as ovulation induction also appear to be safe if indicated. Questions? Did I lose you?
No, I'm here.
Oh, it did,
yeah,
and it did.
no.
I did note this. This is new that I did not see before. Apparently, there's new evidence or data, and of course, you never say data on this exam, regarding the risk of recurrence of borderline tumor with postmenopausal hormonal therapy. Although some data suggest that hormone therapy is a risk factor for developing the disease. I found that interesting.
Yeah. So for borderline, no tumor markers, no adjuvant therapy.
Now that's it's like, I guess, a recurrence, but even then it usually doesn't help you.
Yeah. Okay. And I do know that we have to do at least a unilateral salpingo oophorectomy. I don't know why it did not come to my mind at the time.
But you ended up, see, I mean, but it looks to me, I still would say, of course, you would still send her to the oncologist, but you didn't assume that there was going to be a problem. It was going to be borderline. Oh, surprise, borderline. So you did do a cystectomy. So is the requirement that she has to go to the operating room? Of course, the oncologist will make that decision, but you just have to monitor her a little bit more closer and tell her you have a higher risk of a recurrence.
Mhm.
So I have a
That
question
sounds
from
good.
Sienna. So for this patient who already had her surgery, she would have to be brought back to the OR for unilateral oophorectomy and staging, right? I think it all depends with shared decision making. You know, I mean, it looks like you have a greater risk of a recurrence if you just did the cystectomy. But of course, you did the cystectomy not knowing that it was going to come back low borderline potential. So I have Larissa. It looks like she's a GYN oncology fellow. She would offer the patient laparoscopic USO and biopsies. There we go. No tumor markers up front. Would surveil every 6 months with transvaginal ultrasound and CA 125 times 5 years, although there's still risk of recurrence greater than 10 years out. But if they're saying CA 125 is a no value, why would you do the CA 125? Would there be a change in that level, Larissa? I'm waiting for her response. I'm just telling you, I'm not an oncologist in any way, shape, or form. Okay, Larissa wants to get unmuted, so let me go find her in this big list of names here. Give me a second. Are you there, Larissa? Says you're self-muted. Oh, it looks like it was going to turn green, and now it's not. Well, we're trying to unmute Larissa. Tali, you're going to be next, followed by June. Okay, you'll be the next two on the hot seat. I can't unmute you for some reason. There you go.
Can you hear me?
Yeah, we can hear you.
My co-fellow and I are debating this right now because we feel differently about the CA-125. I think we both agree
Okay.
that we wouldn't get it immediately after surgery, especially in a premenopausal woman, because it's likely to be elevated anyway, just from like inflammation and being premenopausal. I personally, anecdotally, have seen that our staff will follow these patients with tumor markers regardless of age over time, just so that you have like some data point. But I think you also have to kind of talk with the patient about, you know, in a premenopausal state, even if it's a little bit elevated, what are you going to do with that information? And remember that any number elevated that's less than about 200 is not really going to be sensitive for very much at all. So, I mean, I personally think that it's reasonable to offer it as part of your surveillance plan, but certainly not required. And then my surgery plan is as what you saw.
So you would take her back to the operating room for USO?
I would. I mean, I think, you know, we're not going to like say that we would quote data, right, without having read it or
Right.
all those things. But there is data that you can just surveil after completed cystectomy and not offer USO. But for me personally, I would offer her USO and biopsies.
So shared decision-making with the patient.
Mm-hmm, mm-hmm.
Now, do you recommend after she's done with childbearing, taking everything out or no?
I mean, again, that I also think is more of a shared decision-making situation.
Sure.
I think if somebody that has like a strong family history or other reasons for you to consider that, I think that's very reasonable. But if there aren't any other risk factors and the patient would prefer to avoid surgery or they're not otherwise like a good surgical candidate, I don't know that you need to go like making trouble for yourself.
Okay. All right. Thank you. I mean, again, I'm just a generalist. This is up to date. So just to get, I could see this become a question and I'd be like, what? That's a tough question. For you, it'd be easy being an oncologist.
Yeah, they probably won't give this to me, so.
You're going to get the really bad OB question, right? All right. Well, I really appreciate the information, Larissa. Thank you so much. Okay, Tali, we're going in your direction. It says you're self-muted.
Hello?
You're there, Tali?
Yes. Yes, I am.
All righty, man. All right, excellent.
Can I ask a quick question about this last case? When you first put in the vignette, I was a little confused about low malignant potential tumor and what that meant. I
Right.
think when I trained, we mostly referred to it as
borderline.
borderline.
Right.
Could I
So then
have asked for a clarification and just asked if
Oh, man.
they were referring to a borderline tumor?
You know, that's a tough one because they really will not answer questions. Maybe you get lucky, you know, because there's new nomenclature. Low malignant potential tumor is borderline now. Painful bladder syndrome is interstitial cystitis. I don't see a problem with you saying, if you mean what I understand as a low malignant potential tumor being a borderline, I would do this and this and that. So hopefully you put that corollary.
Okay.
If this is what used to be known as a borderline tumor, this is what I would do for this patient. And hopefully you don't din yourself by they're like, well, you know, she's
Alright.
talking gibberish about because you misunderstood the question. Does that make sense?
Yes, it does.
So anytime you're like, you know, in doubt and they're not gonna, I mean, I know they didn't answer questions. They just stared at me and went, And so I just said, well, if my understanding is correctly, I would do this, this, that, and the other. And you know, I would assume if you're answering it incorrectly because of your misunderstanding, they would have to correct you.
Okay.
Am I making sense?
Yes.
Okay. All right. You're a generalist, correct?
Yes.
Okay. I see I have other questions, but we're going to go on to the next case, and then we're going to answer everybody's questions at the end. Okay. So a 37-year-old woman is post-op day number 1 from a complicated total abdominal hysterectomy with an estimated blood loss of 2 liters and subsequent transfusion. On morning rounds, you note a blood pressure of 85/50 and a urine output of roughly 5 cc's an hour. How would you evaluate the patient?
I will go to bedside and evaluate her status, if she was comfortable, if she was in severe pain, get a set of vital signs, and confirm with the nurse that that was the correct output for the night. I would also flush the Foley catheter, potentially consider replacing it and seeing if there was an obstruction with incorrect measurement. I'll get a set, do an abdominal exam to see if there was increased pain, and do a set of labs, including a CBC.
Let's hold the labs for a second. Anything else that you would do in your evaluation, your history and physical?
Repeat the blood pressure, see if she was tachycardic, look at her pulse ox to see if there was any hypoxia or difficulty breathing.
Anything else you'd be looking for?
Bleeding on a pad, and listen to her chest and heart to see if there were any abnormalities there.
What would you be looking for? Listening to her heart and lungs specifically.
Or it could be retaining fluid and have pulmonary edema or like lung effusions, and yeah. So that would be my initial evaluation.
So what diagnostic studies would you order and why?
So I would start with a CBC electrolytes, and to look for acute blood loss or blood loss that was not counted at the time of surgery or post-op bleeding. I would look for electrolyte imbalance, and look as well at her creatinine to see if that she was in acute kidney injury.
So what creatinine would make you worried for AKI?
I would have had a baseline creatinine on this patient, and if she had a normal creat, probably something greater than 1 or 1.5, depending on what the baseline was. I would be concerned.
Anything else that you would look for diagnostically?
I would consider imaging as well to look for any complications related to the surgery. So that could be incidental organ injury. It could be bleeding from one of the pedicles. So I would consider a KUB to start, and then do a CT, abdomen.
So what would the KUB show you?
I would actually consider the KUB if it was a little later, if I was concerned for ileus. I don't think that at this point, the day after, she would have an ileus yet, so I would probably just go ahead with the CT abdomen.
So are you saying the ileus would give you a low blood pressure and a low urine output?
No, I'm just correcting myself and thinking out loud. No, I would not start with a KUB. I'll go straight to the CT.
And what do you think the CT would tell you?
There's if there is intra-abdominal or retroperitoneal bleeding, for example.
Would any of the lab work help you with that as well?
It would, but it would help me identify the location of the bleeding if it was retroperitoneal or if it was from a pedicle.
Okay. So how would you manage the patient?
So depending of what my results were, so if she had, it looks like she's hypotensive, I'm assuming that she has had significant blood loss. So I would consider transfusion if she was persistently hypotensive on repeat vital signs and on clinical assessment. Probably transfuse her at least 1 unit if her hemoglobin was less than 7, and look for clinical improvement. If there was concern for ongoing bleeding, then I would consider serial CBCs if she was stable after transfusion, to evaluate if there was any need for intervention, which could include a laparoscopy or a laparotomy to evaluate for intra-abdominal bleeding to address that. For example, if it was a pedicle, a laparoscopy could be enough if the patient was not acutely bleeding to religate or cauterize a pedicle that was bleeding. If it was retroperitoneal bleeding, then I would evaluate that, see if it was expanding on the laparoscopy, and consider calling vascular surgery to help me open the retroperitoneum and address the bleeding.
So anything else you would do in your management? Take her to the OR, open up the retroperitoneal space.
Well,
Is that
she's been hypotensive, so I would consider at least 1 to 2 liters of IV fluids. But this was a case of massive hemorrhage, I would probably initiate a massive transfusion protocol in the way to the operating room.
So what is acute tubular necrosis and how is it diagnosed and treated?
Acute tubular necrosis is usually due to decreased perfusion to the kidney, which could be due to acute blood loss. It is usually initially managed with fluid replacement, and it can have an increase in creatinine that is pretty substantial. Initially, the treatment, from what I can recall, would be conservative with fluid replacement and observation, serial assessments on the creatinine. I would imagine that if this didn't not get better with the things I've mentioned prior, and if there was significant concern for kidney damage with increased creatinine, I would consider dialysis, but I would not imagine that acute tubular necrosis would get to a dialysis point in most cases.
So how would you confirm the diagnosis of ATN?
Why?
I am not sure, so I would have to look that up.
And do you know what happens to the kidney, its kidney's function with ATN?
I remember that there is a decrease in urine output, but I don't remember the physiology at this point.
Whatever the offending agent was, and then they have.
With what?
Okay. What'd you think?
Oh, this was so difficult.
I mean, The only thing that I was questioning, and when you said I would take her to the OR so I can open up her retroperitoneal space, but you said you would have the vascular surgeon, because that's, because the space you hope it tamponades, but once you open it, there's no tamponading, right?
Yes.
But if you have the vascular surgeon with you, okay, that's good. Don't do it by yourself,
Yes, that would be a last case scenario.
Yep.
Mhm.
Yeah, any specific questions before we go over this one?
I feel like I had a hard time kind of like creating like different diagnoses and then being like, well, if I would because it's very open, it's an open question.
It is.
Just like saying like, okay, so if I listen to her lungs, like that's what I'll be thinking, and just like going slowly through my differentials and being able to.
Right, but that's what they want. That's what they want you to do, or see, or discuss. Again, if your thought process on answering the question to your evaluation, the diagnostic studies and all that is correct, you're not going to get dinged because you didn't know the zebra or the fourth question or the fifth question.
Okay.
So don't think you didn't have that as part of your quote unquote differential, because I didn't ask you for a specific differential. But at least if you evaluate her evaluation's appropriate. It's like, well, I would evaluate her lungs, her kidneys, da 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 da, and then for your diagnostic, you said, well, I'm gonna get a CT of the head. Well, you didn't say you do anything evaluation wise for her head. You know what I'm saying? So that's out of left field and just wouldn't look right.
Okay.
Now you also I do this on purpose. On the exam itself, they're not going to stop you to say, hold on, don't bring up any diagnostic studies right now. The reason I do it is because some people listen to this recordings. So some people would stop the recording and they answer the question out loud, and then they could press play and see what we say. So then that way it doesn't throw off for the next question. So I do that on purpose. But on the exam itself, they're not probably going to do that. So I want to preface that. And I remember saying a lot in my exam, like I said previously, I would do the CBC, CMP, da 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 da. Does that make sense?
Yes.
Okay. Because I always equate evaluation as history and physical. Can you do lab work and all that? Yes. But always don't forget your history and physical. That always goes first. It's not, let's get a CT scan first and then we'll figure it out. You got to do your H&P followed by your diagnostic tests. So I stop you guys, so then that way, if anybody's listening to the recording, they can get a benefit with answering the question. So I remember a lot of times I'd be like I said previously, I would do a CBC, CMP, whatever the case may be. And then they'll cut you off real quick and move on to the next one. Okay. All right, so how would I manage the patient or diagnostic studies? CBC, orthostatics. The urinalysis, you may see muddy brown granular epithelial cell casts, increase from baseline serum creatinine. You could do a fractional excretion of sodium, or the FENA. Pre-renal is less than 1%. ATN is greater than 2%. And then 1 to 2% is inconclusive. If you did a renal ultrasound, the kidneys would be normal size. What happens is a loss of concentrating ability. It's an early and almost universal finding at ATN. Okay, so the causes of oliguria can be sorted in the following categories: pre-renal, decrease in renal perfusion, intrinsic renal issue, or post-renal obstruction. If she's hypovolemic, I would order like a 1 liter bolus of normal saline or LR to be given rapidly and assess for patient response. Inadequate intravascular volume can lead to renal hypoperfusion and acute renal failure, usually due to the ATN. Okay, 3 major causes of ATN is renal ischemia, sepsis, and nephrotoxins. Although renal ischemia is the most common cause of ATN, the sensitivity of individual patients to a decrease in renal perfusion is variable. In some patients, a few minutes of hypotension is sufficient to induce ATN, whereas others are able to tolerate hours of renal ischemia without structural damage to the kidney. Ischemic ATN typically lasts 7 to 21 days, with most patients returning to or near their previous baseline level as the necrotic tubular cells regenerate. Diuretics augment urine output, but they do not have any effect on renal perfusion. You use this only to manage volume status. Management is primarily supportive, and the key to management is ensuring adequate renal perfusion is achieved by maintaining hemodynamic stability and avoiding hypovolemia. Okay. Discontinue any medication that can affect renal function by direct toxicity, such as metformin, and use non-contrast imaging studies only. Worst case scenario, and you said this, you would require temporary dialysis. Questions on that?
No, not on my end. I thought it was pretty difficult though.
That's a hard question. I would have cried. I would have cried if I got this in my exam.
Okay, I'm not
But you
alone.
know, I aim to do hard, so hopefully you get the easy. You know what I'm saying?
Exactly.
So you be prepared for the scary
All right.
ones.
Thank you.
Okay. All right. Good job. And I'm going to go to the last question, and we'll answer all your questions, or the next case. And we'll answer all your questions. We'll take as much time as it needs. I am going in the direction of June. I just have to find her because I did see her earlier here. Are you there, June?
Yes, I'm here.
All righty. Generalist, correct?
Yep.
All right. "59-year-old diabetic woman presents with the following on vulvar inspection. How would the patient clinically present?
So in this case, I would expect the patient to present with complaints of increasing vulvar pain. I would also expect her to have noticed an abnormal discharge from the area, possibly some bleeding. I think those would be, and then probably like warmth to the touch in the area. And then if she's done any inspection of that area, just increasing erythema. And I would expect this to kind of happen over the course of a couple days or a week.
And what do you think is going on in this picture?
So from what I can tell, so we're looking, looks like we're looking at the introitus, and then she has kind of this symmetric erythema, and then she has these lesions on, it looks like the, it's kind of hard to tell. So I assume that's kind of the introitus there, but she's kind of got these like macular lesions bilaterally with some ecchymosis. That is what I'm able to discern from the photograph.
What diagnostic tests would you order and why?
So in this patient, when I'm initially seeing her, I would want to get a CBC with differential. I would want to get kind of, especially depending on her like vitals, if she's febrile, I would want to get possibly blood cultures. I would want to get a culture of the lesions as well. And then given her risk factors for a more serious, deeper infection, I would also...
What would be a more concerning, deeper infection?
Specifically, I would be thinking of necrotizing fasciitis.
So how would what would you see on physical exam or note on physical exam if you had necrotizing fasciitis?
Right. So in that case, I would Honestly, I haven't seen too many of these cases, but I would expect the skin to kind of have a devascularized appearance, maybe be like violaceous or black due to the lack of blood supply. And then even though the patient initially, I would expect the patient to have a lot of pain, but in the devascularized area, potentially she would have loss of sensation.
Anything else you would note on physical exam if you had necrotizing fasciitis?
Sure. So you could potentially note a sub-Q emphysema.
Anything else?
Not that I can recall at this moment.
Any other diagnostic tests? You said you do cultures, do a CBC. What else?
In this patient, I would get imaging, such as a CT abdomen pelvis with contrast.
And what do you think it will show you?
So I think that it kind of depends on what's going on, but if she has like a cellulitis, sometimes it just shows like inflammation and fat stranding.
So let me ask you this. Do you think what she has going on in the perineum there, that's just cellulitis or a little bit more than that?
Cellulitis would be pretty unlikely with the image that you've presented. So I think that if we are, assuming that she does have necrotizing fasciitis, then you could, with the CT, you would be able to assess how deep the infection goes. So you could potentially see the sub-Q emphysema on the CT in addition to like the signs of inflammation like fat stranding.
So let me ask you, what is necrotizing fasciitis?
So it is a very serious infection that I believe in many cases is caused, it has a what am I trying to say? That it's not just polymicrobial, is what I mean to say, but especially we think of like anaerobic bacteria, and it basically causes devascularization and devitalization of the tissue, and it's a surgical emergency.
So is it diagnosed through a CT scan, any specific lab work, or is it clinical diagnosis?
So I would say that really your suspicion for it should come from your history and physical, but the CT can provide confirmation of your suspicion.
So let's say you have a patient, she looks real sick. You're going to wait for the CT scan to be done? If you said it's a surgical emergency.
Right. I will say that in like if this patient were coming to so I would say in general, if a patient is very unstable and I think that she needs emergent intervention, then there are times that I would proceed to the OR without waiting for all the imaging I would like to get. I think in cases such as these, given the practice setting that I'm in, I do think that in most cases it would be feasible to quickly get a CT scan and then have the radiologist give me just a quick read about what is seen. That simultaneously, while the CT scan is happening, I would, be reaching out to the consultants I would think I would need. I would be notifying the OR, making sure the patient has type and screen, like broad spectrum antibiotics going. So I think realistically, I would be doing those things concurrently.
Okay. How would you manage?
So for this patient, if we're talking about necrotizing fasciitis, then she would need to go to the OR. So she would need broad spectrum antibiotics, and she would need.
So what would you start her antibiotic wise?
So I would probably do vancomycin. I think there are probably multiple effective regimens, but I think vancomycin and Zosyn would be kind of the combination that I typically start with.
And why would you use those specifically?
So it would offer coverage of a wide spectrum of bacteria, like MRSA, gram-positive, gram-negative, anaerobes.
What else would you do? So you start her on antibiotics.
Yes, and then I would, so ultimately this patient needs to go to the OR for a debridement. Typically I would do this ideally with the aid of GYN oncology or general surgery to make sure that she has the best surgical outcome.
And by debridement, what do you mean by that?
So you would need to remove any of the devitalized tissue to get to healthy tissue. Yeah, I think that's essentially the basics of that.
So what increases the risk for this?
In this patient, without knowing more about her, I would say probably her most salient risk factor is the fact that she has diabetes. So diabetes, especially poorly controlled, would increase the risk for this. Any type of trauma to the vulva has the potential to result in an infection that can eventually progress to this type of medical issue. So, for example, if she, shaves in that area, and that can increase the risk. I'm trying to think if there are other big ones. I know really the biggest one is probably diabetes, but yeah, any sort of trauma or infection in that area that goes untreated. If she has any type of surgery in that area and has a post-op infection that's not recognized early. Yeah.
Is there any criteria that you know of that would give you more of an indication of a poorer outcome?
Honestly, I'm not aware of anything like that. I would have to look that up.
Right. What'd you think?
Not my favorite topic.
Mine either.
Uncomfortable. Yeah, I really, man, I would bounce this in real life. I would bounce this patient to GYN oncology so quick. But it's good to talk about, I guess.
They're gonna give you these weird. I think they'll get you some. There's gonna be some structured cases that are gonna be a little bit on the odd side, and they just want to freak you out.
Yeah.
Hopefully not, but you got to be prepared. Okay. Any questions before we go over this one?
I guess like I can't really tell on the image that like brown area almost looks like stool, but that's not what
it's just dead
it's
tissue.
Oh, okay, got it.
That's what it looks like to me, like not good.
Yeah, right. But yeah,
I'm not an
otherwise,
expert. I'm not an expert in any way, shape, or form. I mean, I think you did your question. I thought your thought process was good. I know it's kind of nerve-wracking when you see that and you go, And then I said something and you just jumped on the necrotizing fasciitis. I don't know if it was something that I said.
I don't. I don't know. I think it looked clearly like a very serious infection, and so I kind of just went worst case scenario, and I don't
Even if it wasn't necrotizing fasciitis, if it's a bad infection, I mean, still the recommendation would be a debridement, right?
Right.
I don't know if that black, whatever that is, black, green, is that going to go away with just antibiotics? I don't think so.
No.
You know, yeah, it looks bad, poor thing. Any other questions?
No, I'd love for you to review the case.
All right. So this is up to date. Not that I'm an expert in this in any way, shape, or form. So necrotizing fasciitis is an infection of the deep, soft tissues that results in progressive destruction of the muscle fascia and overlying subcutaneous fat. Infection typically spreads along the muscle fascia due to its relatively poor blood supply. Muscle tissue is usually spared because of its generous blood supply. Development of anesthesia may precede the appearance of skin necrosis. Initially, the overlying tissue can appear unaffected. Therefore, necrotizing fasciitis is difficult to diagnose without direct visualization of the fascia. It could be caused by E. coli, Klebsiella, Enterococci, and the following anaerobes: Bacteroides, Clostridium. Clinical manifestations include erythema without sharp margins, edema that extends beyond the erythema, severe pain out of proportion to exam findings, fever, crepitus, skin bulla, necrosis, or ecchymosis. Laboratory results are generally nonspecific. Diabetes is a particularly important risk factor involving the lower extremities, perineum, which is called Fournier's gangrene, and the head and neck region. In addition, use of sodium glucose cotransporter 2 inhibitors, Jardiance, has been associated with Fournier's. Necrotizing infection usually presents acutely over hours. Rapid progression to extensive destruction can occur, leading to systemic toxicity, limb loss, and/or death. Therefore, early recognition of necrotizing infection is critical. Surgical exploration should not be delayed when there is a clinical suspicion for necrotizing infection while awaiting results of radiographic imaging, culture results, or other diagnostic information. It is a surgical emergency. Radiographic imaging studies should not delay surgical intervention when there is crepitus on examination or rapid progression of clinical manifestations. The goal of operative management is to perform aggressive debridement of all necrotic tissue until healthy, viable bleeding tissue is reached. Inspection and debridement in the operating room should be continued every 1 to 2 days until necrotic tissue is no longer present. For severe necrotizing infection involving the extremities, amputation may be needed to control the infection. During the surgical exploration, the tissue is necrotic, the fascia is swollen, dull gray in appearance with a thin exudate without clear purulence, and easy separation of tissue planes by blunt dissection. Treatment consists of early and aggressive surgical exploration and debridement of necrotic tissue together with broad spectrum empiric antibiotic therapy to include MRSA coverage such as vancomycin and hemodynamic support. I usually call it like a dishwater color to fluid in the incision. Administration of antibiotic therapy in the absence of debridement is associated with a mortality rate approaching 100%. Provided an appropriately trained surgeon is available, do not delay care for transfer. Early debridement is associated with better outcomes. Survival is significantly increased among patients taken to surgery within 24 hours after admission compared with those in whom surgery is delayed. And survival is further increased with earlier surgical intervention within 6 hours. So what increases your risk of mortality? WBC count of greater than 30,000, neutrophils greater than 10%, a serum creatinine of greater than 2, greater than 60 years of age, strep toxic shock, clostridial infection, delay in surgery greater than 24 hours, infection involving the hand, neck, thorax, or abdomen. Okay, questions on that? Did I lose you?
No, you did not. Sorry, I was getting some text messages, so I don't want to be distracting. But did you, so for what I said when you asked me if I would delay for imaging, I guess was my response to that bad? Or
I don't think so. I think all of us always go to CT scans, right? But I think, but you're doing all these things, you know, because you don't have the results. So let's say your creatinine comes back at 3. Well, you know something's going on, and you're not going to do contrast if you were going to do a CT scan. You know what I'm saying? So you start, when you start getting your labs back, you start saying, hey, something's going on here, right?
Yeah.
You know, you do your cultures, lactic acid, the septic workup, right?
Yeah.
Doesn't everybody have a protocol, septic workup, which gets all the IV and all this stuff? So
it's okay to say that you're kind of like working on multiple things at once while
yes,
kind
I think it was
prepping.
perfectly fine.
Okay. Okay.
Of course, this is like the imaginary patient. Of course, when you
Right.
go to the ER, all this is already done, right?
True.
You already have the CB, you already have, but it's like, oh, you're in the ER and this lady shows up. What are you going to do? You know,
Mm-hmm.
by the time they call you, everything's already done. CT scan too, right? Right? They're going to call you. CT scan looks bad,
Yeah.
right? Again, I'm not an expert, but it looks like she shouldn't be transferred from one small hospital to a bigger hospital. They should just do the surgery in that hospital. That's what it looks like. From what Up to Date was prefacing. Other questions?
No, thank you very much.
Okay, great job. All right, I'm sure people are going to have lots of questions, so let's start looking at those. And I know I have to show Tawana some questions here. All right, so let me see here. So Emily's asking, I guess, for a case, the case before of the low malignant potential tumor. Are there any associated tumor markers? According to Up to Date, they're of no value. However, Larissa says that I guess in her practice, they do follow people with their CA-125s over many years. Adjuvant therapy, to my understanding, if it's a low stage, no, it's controversial. Usually you don't give adjuvant therapy. I guess if you have a recurrence and it's a greater stage, because borderline is staged, not staged, they have their own staging system. I think there's a borderline staging system. Don't quote me on that. Compared to let's say ovarian, it's not necessarily just ovarian. It has its own staging system, I believe. Don't quote me on that. So Adriana's asking, would you recommend a hysterectomy if the cyst fluid spilled? I don't think that would be the case in a borderline. I think you would keep the uterus, Adriana. So you is saying, I was told you can skip structured case if you don't want to talk about a case. Is that true? Well, if you skip a case without discussing it, that's 0. You're gonna get 0 points. And I don't think that looks very positively. So I would answer every question they present to me, but that's just me. Because all they're going to remember is that you skipped things, So Ashley's asking, where is her vulva, urethra, and vagina? I'm assuming it's all eaten up in here somewhere. I'm assuming here somewhere. This is the best picture I could find online. It's actually German. The Wikipedia and the German website, I guess. German Wikipedia. I'm assuming it would be in this area, but I could be wrong. So then I have Larissa indicating, think about borderline tumors as being, as being on a spectrum with low-grade serous cancers. If biopsies come back showing invasive implants, then we are concerned for occult low-grade disease, and in this setting might consider adjuvant therapy. This is a more rare situation. For non-invasive implants or cyst rupture, intraop, just surveillance. Thank you, Larissa. Then Clarissa's asking, in scoring of oral boards, you get negative points for answering a question wrong. I don't think you get points deducted. I don't think you just get points added. Okay. But again, I'm not an examiner. I don't know. That's all, behind closed doors. So I don't think you get negative points. You just won't get the point. So I'm assuming if you did well on what's your differential, what's your evaluation, what's your management, you do those correct, and then you can get the zebra. You know, out of those 4 questions, you got 3 out of 4. That should be a pass. Okay, in my mind. So Ashley's saying, because I know she's an Urogyne, that this looks like a fistula. Wow, that's a big fistula. I don't know. This is what was under necrotizing fasciitis. Again, it's the best picture I could find. Don't know what to tell you there, Ashley. So any other questions? Because whatever's going on doesn't look pretty. So you're gonna get a fistula to your gluteal area? Wow. Have you seen that a lot, Ashley? If you're saying it's a fistula? So Chihiro's saying, my first guess for the picture was lichen sclerosis because of the loss of architecture. Is that an unreasonable answer? I think there's a little bit more going on. You don't have that cigarette white looking paper. I mean, you know something bad's going on. This is what I've seen. So I can't say, lichen sclerosis looks more red. The skin could be like instead like more like, I'm not gonna say raw, but raw because the patient could be scratching, but not to look in some areas necrotic, you know? So Ashley's saying, no, it just looks infected and not normal anatomy. You know, I mean, it just looks like bad stuff. I mean, it's the best picture I could find for necrotizing fasciitis. Then I have Melody saying, if you get a photo and you do not interpret the diagnosis correctly, but answer the questions with what I think it is that bad? No, I don't think so at all. But you let them know that. I go, I'm thinking what I'm seeing here is this. If that's correct, I'll do this, that, and the other. They can't deduct points in that respect because you're answering to what you think is correct. Nothing in the follow-up questions would confirm it's talking about necrotizing fasciitis. Yeah, exactly. Sometimes you might get that last zebra question and they'll tell you what it is. Well, what's acute tubular necrosis? But they don't have to do that either. Okay. I mean, you got to do something for her. And I think just doing antibiotics alone may not cut it. Because I think you're beyond just antibiotics. You need to do some debridement. Okay. Any other questions? I'm just looking down the line here. Does anybody want to ask a question? They want to raise their hand? Victoria's asking, what's the preferred antibiotics for the necrotizing fasciitis case? I think what June brought up was, I think, spot on. I think you need to include Vanco in some perspective or respect because of the concern for MRSA. So I thought what she said was spot on with the, I believe she had said Zosyn and Bank. So I think that would be fine. I mean, of course, you're going to call ID probably for their input. And then Adriana is saying clindamycin for toxin. What do you mean by toxin, Adriana? Antitoxin. Still don't know what you mean by that. So you're talking about C. diff? Is that what you're talking about, Adriana? I don't know. I mean, I thought Vanc and Zosyn would cover everything. I'm not an ID specialist, Adriana, so I don't know what to tell you there. I don't recall in my reading of the subject that they recommended Clinda, but I could be wrong. I'm trying to unmute you, Adriana. Are you there? So what are you trying to get to?
Sure. Yes, at residency, when we were going through necrotizing fasciitis, we always made it an emphasis to add clindamycin to the regimen in case the bacterium was releasing a toxin.
And what toxin are they releasing?
I think it had to do with like if it was a Clostridia bacteria.
I don't know,
No,
to be
okay.
honest with you.
I would.
You got me, man.
Yeah, I'll look it up in case I'm confusing it with something.
Be up to date, but you know.
Yeah, I'll research it. Maybe I'm confusing it with something.
But Vanc won't cover that because Vanc covers a lot of stuff.
Right, we used to do vancomycin, zosyn, so exactly what we were saying, and then we would add clindamycin. But I would double check just in case I'm confusing it with something.
I don't know what to tell you. You got me on that one. My apologies if Clinda is one of the ones that you start. I don't recall. Okay, so Chikara is saying yes. Up to date says all 3 for group A strep. Well, there you go. I stand corrected. But be careful for C. diff, because that's what Clinda will do for you. And this person's going to be sick.
Right.
Yep. Okay, so there you are. Thank you, Shakira. So my oversight. I'm not an expert in any of these things. I'm a generalist, just like all of you, for the most part. So there we are. Let me write that in my notes for next time. Any other questions? Oh, I have to show the pictures for Tawana. She's still on the call. Let me see. Okay, thank you, Adriana.
Thank you.
Yep. Okay, Tawana's still on the call. Let me just get to that picture she wanted to see. Let me just plug here. I know I blacked out my screen because I'm going to be flipping through things. So which one are you looking at? The second one? That one? Tawana? Okay, we'll leave it there for you. No worries. This is straight from the Atlas of Pelvic Surgery. You can look it up online. It's free. Just enter site and it's free. So anybody have any other questions? I really appreciate everybody that participated today. These were not easy topics. I think everybody did a great job. Any other questions? I know we have a caseless defense webinar tomorrow. Again, we have names that we're supposed to put on the hot seat. If somebody's not on the call, we just skip them and we'll get them at another webinar. But we're putting people on the hot seat pretty consistently. So I think it's a good system. It's working out pretty well. So hopefully people are feeling that they're getting their opportunities on the hot seat. So I'm going to stay on the call for a couple of minutes to see if anybody has any other questions. They want to do a private chat. But I really appreciate everybody.